Popma, Vice President, Chief Medical Officer at Medtronic for Structural Heart, Coronary, and Renal Innovation. And it's my pleasure to present to the Jeju Valve Conference a talk entitled Building the Evidence for Valve Performance with Evolute from Acute Hemodynamics to Late Valve Integrity, Now and in the Future. I want to thank Dr. Cheng and Congress organizers for this important invitation. My disclosures are I'm a full-time Medtronic employee. I want to make 5 very brief points. First, we now know that transcatheter valve design plays an important role in determining late valve performance. You're all well familiar with our superannular self-expanding Evolute design with its long reverse-canted porcine pericardial leaflets, lowering the leaflet stress during the cardiac cycle. This results hemodynamically in low gradients that are sustained out to 5 and 10 years. There's a very strong inflow that's conformable to the annulus and able to seal around left ventricular outflow tract calcification. We know that the porcine pericardium is thinner, and the way it's constructed has less leaflet stress, 40% less leaflet stress, than with balloon expandable technologies. So we've known about the design. Now, more recently, I'll show you we've linked that valve design with valve performance and clinical outcomes. So as we start to treat patients who are lower risk for surgery, we have to understand the fact that the patients are younger, they'll live longer, and they'll want to have more important outcomes. So I'd like to share very briefly in a few slides what we've learned from our Evolute low-risk trial that shows superior valve performance compared to surgical valves, and at 4 years shows a trend towards improved clinical outcomes with Evolute. Now, everyone's aware of our cascade of studies from patients who were extreme risk or inoperable to those who are high risk and randomized to surgery, and those who are intermediate risk and randomized to surgery. In 2016, we began to study patients who were deemed by the heart team to be low risk for surgery, an average age of 74, an STS of 2. We randomized 1,414 patients to either TAVR or surgery, and we followed and reported those patients each year. At our TCT conference this year in 2023, Mike Reardon presented the 5-year or the 4-year results from the Evolute low-risk trial, and showed that the endpoint, the primary endpoint of all-cause mortality or disabling stroke, was progressively divergent from 1 year to 2 years to 3 years to 4 years, so that all-cause mortality or disabling stroke occurred in 14.1% of patients treated with surgery and 10.7% of patients who were treated with Evolute. Most importantly, this benefit was due to a separation in mortality from 1 year to 2 years to 3 years to 4 years, a progressive separation of the curves from 12.1 mortality at 4 years with surgery and 9% in those patients treated with Evolute. Very, very important, particularly comparing the contrasting event curves that occurred with the Partner 2A and Partner 3 trials. Now, our next step was then to prove what is the benefit of the superannular technology for TAVR compared to other annular devices like the balloon expandable SAPIEN. And we performed and presented at the ACC meeting this year with Howie Herman the results of our SMART trial, which focused on patients with small aortic diameters with a heavy enrichment with women. And we showed that there was superior valve performance in patients treated with self-expanding Evolute compared to those treated with balloon expandable. Let me show you a little bit more detail. We felt it was important that we would actually do a head-to-head comparison, a randomized clinical trial, excluding all of the unmeasured confounders that affect other sorts of retrospective analyses, even with propensity matching. So we enrolled 355 patients with Evolute and 361 patients with balloon expandable TAVR. We had two primary endpoints. First, we wanted to prove that Evolut was safe. So we had a non-inferior endpoint with composite mortality, disabling stroke, or heart failure hospitalization through 12 months. We also wanted to demonstrate that Evolut had a better valve performance than the balloon expandable. So we looked at bioprosthetic valve dysfunction through 12 months. I'll show you those results. First of all, we had a very strong and rapid recruitment. We had an average age of 80 years. We had an STS risk score of 3.3. But the cumulative event curve is really important to examine for our first endpoint, which was the non-inferior endpoint of mortality, disabling stroke, or heart failure hospitalization. And we found that we were non-inferior. In fact, the cumulative event curves were higher for the balloon expandable sapien valve, 10.6%, compared to the self-expanding 9.4%. Not statistically different, but numerically certainly in the right direction for Evolut. But most importantly, and I think surprisingly, we found that there was a tremendous reduction in the occurrence of bioprosthetic valve dysfunction through 12 months using components of hemodynamic structural valve deterioration at gradient over 20, non-structural valve deterioration, severe PPM, moderate severe PVL, thrombosis, endocarditis, aortic intervention. And we found at 12 months that 41.6% of patients treated with the sapien valve had some evidence of bioprosthetic valve dysfunction, compared to 9.4% with the Evolut group. We looked at all the components in a lot of different ways, and we found that the very important flow-independent measure of Doppler velocity index showed a higher DVI, 0.63, with Evolut compared to 0.44 with sapien. Severe PPM, 10% with sapien, 3% with Evolut. And most importantly, we saw lower rates of total aortic regurgitation at 1 year with Evolut than sapien. It was 19.3% for sapien, which is a good number for the sapien randomized trials. And it was 14.1% with Evolut, we believe, because of better implantation technique, such as things like cusp overlap. We also found that there was an improvement in quality of life. Using the VARC3 indices of how much an improvement one gained, we found that more patients had substantial improvement in their quality of life in those who were treated with Evolut compared to sapien. So this is a first step. We'll be reporting these outcomes all the way out to 5 years. It's a first step. We found numerically better 1-year clinical outcomes with Evolut compared to sapien, and we found substantial differences in valve performance, and we'll see how those manifest over the next several years. Well, it's very important then, as the fourth point, to say we need to be able to understand whether poor valve performance, as we have measured it, is associated with worsened 5-year clinical outcome and rehospitalization with both TAVR and surgery. So we relied upon an analysis of all of our high-risk and intermediate-risk patients and our concomitant registries, 5,500 patients, and we defined bioprosthetic valve dysfunction as structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis, and using VARC3-like criteria for a change in gradient, more than 10, and a gradient over 20 to define the structural valve deterioration. And we used very sophisticated analysis, including an analysis that looked at outcomes using death as a completing risk in this elderly population. Here's what we found. We found that first, bioprosthetic valve dysfunction occurs early. It begins to manifest itself at 30 days. And we said by 5 years, the rate was substantially lower, significantly lower in patients who were treated with CoreValve and some Evolut, 9.6%, then in those patients treated with surgery, 15.4%. So an early and sustained reduction in bioprosthetic valve dysfunction in those patients who were treated with CoreValve. We also found a very important finding too, was it wasn't just the small annuli, although there was a larger effect in the small annuli, But patients who had a CT annual diameter of over 23 also had a beneficial reduction in biapacific valve dysfunction, 9.8% with core valve and 14.2% with surgery. Here's the most important point, and that is we were then able to correlate the occurrence of biapacific valve dysfunction, which began at 30 days, with 5-year mortality, 5-year cardiovascular mortality, 5-year hospitalization. And this was true in the pooled analysis, in the surgery sub-analyses, and most importantly, in those patients who were treated with TAVR devices. And these were very, very important. These were very, very important findings. Finally, the last point, that we want to understand what new valve iterations mean for us. We're not done iterating with Evolut. We want to have better stability and deployment. That's our FX design, which has a nose cone redesign, has a more flexible capsule, has a single spine shaft, has an optimized stability layer, and 3 inflow markers to assessing commissure alignment. And what this results in is better delivery, more coaxial deployment, less TAVR movement on release, and importantly, documentation of commissure alignment. And in the early experience in the United States, reported in a multi-center series by Dr. Gilbert Tang, 96% of patients had commissure alignment, which is incredibly important as we think about coronary access. Guy Adesanya then performed an analysis of now what turns out to be about 125 patients, was able to visualize 100% of patients with the right and the left coronary arteries, and by CT in those patients, found that there was really substantial commissure alignment, no posts in front of the coronaries. Incredibly important for us as we move forward and thinking about coronary access in the future. And of course, our next generation valve design, which has now been approved in the United States, FX Plus, has a large cell window in the middle of the commissure to gain coronary access. So just to finish up what we've talked about over the last 15 minutes or so is, first of all, transcatheter valve design plays a very important role now in determining late valve performance, no question about it. We demonstrated that our low-risk trial has better performance compared to surgery, and that we're showing some trends in reduced clinical outcomes. We did the SMART trial, which was a randomized clinical trial reported in the New England Journal of Medicine showing superior valve performance with self-expanding evolutes. We'll follow these patients out to 5 years to assess their clinical outcomes. We know from our prior series that poor valve performance is associated with worsened 5-year mortality, rehospitalization, with both TAVR and surgery. And we will continue to iterate and continue to come up with new valve iterations that will focus on predictability, easy access, and lifetime management. Thank you so much for your attention.